All right. Well, thank you very much, Alan. Until the break, we're going to continue to bore you with generalities that you probably all know, or at least mostly. And then after that, we'll be getting to specifics and sometimes very specific. So please bear with us. Along the lines of generalities, how many folks have read Weston Price? Probably everybody here? Well, there's still a fair number who haven't. So for those who haven't, please write down someplace Weston A. Price, Price, his book, Nutrition and Physical Degeneration, which one can obtain online from the Price Pottinger Nutrition Foundation. Price was a dentist who took tours in the 20s and 30s to what were called at the time primitive areas. If we want to be politically correct, we would now say areas populated by native peoples eating native diets. We wouldn't necessarily say primitive anymore. What he found and documented with thousands and thousands of photographs as well as copious notes on every continent he visited, which included South America, Africa, the fringes of Europe, such as the Hebrides Islands, are way up in the Alps, Polynesia, Melanesia, Australia, and so forth, is that the people living there, the native peoples who were still following the native diet, were almost entirely free of so-called diseases of civilization, diabetes, high blood pressure, nearly all cancers, heart trouble, atherosclerotic diseases in the heart. One of the things he was able to capture were families in transition. There's a wonderful picture in his book of 2 parents, 9 children, all showing off, remember he was a dentist, their broad dental arches. Except that was mom, dad, and the first 4 kids. The first 4 were conceived and born while mom and dad were living out in the bush in Australia on a native Australian diet. The last 4 conceived and born while they were living in town and eating as the Europeans did. The middle child was a transition child. And it was very clear from the dental arches. The first 4 had, just like mom and dad, broad dental arches, no crowding of the teeth, plenty of room for wisdom teeth. The 5th child, more narrow. And the last 4 kids, lousy dentition. Of course, he was a dentist, and that's what he focused on. But he was able to show in that one family just the difference in a transition from a native diet to a so-called civilized diet. My particular background before medical school was cultural anthropology, and from that became very clear that if you're living in Polynesia and living on coconuts and fish, or if you're living in the north of Canada and subsisting on caribou and the occasional seal, high protein, very low carb up here, high carb over there, you stayed healthy as long as it happened to be, again, the whole native food. Now, Price, of course, was looking around in the 20s and 30s, which was at the very infancy of all of the chemicals that we now have in our environments. So we have to add to the whole food, unrefined, unprocessed as much as possible, minimally cooked. We have to add a few other things. The word organic. Now, people on native diets following native lifestyle didn't need the word organic. They were living it. They just simply didn't use anything else, chemical fertilizers and so forth, and spray the crops with herbicides and pesticides. But we have to add the word organic, and we have to go past that when we're speaking with folks. And excuse me, I know you all do this, but Alan, I feel it's a good idea to get in the basics in the first part so that for the few people who don't know and the people who are listening to the tapes, they'll know that we're not advocating, well, just eat your average diet and take all these vitamins to stay healthy. No, that's not the way it goes. We have to talk to people about free range now. Big deal difference in the omega-3 fatty acid content of cattle that are free-range cattle, eating what cows have eaten for the last, how many hundreds of thousands of years have cows been on the planet? And for all those hundreds of thousands of years, they ate grass and weeds and stuff like that, and nobody put them in a feedlot and gave them grain. That is not a native diet for a cow. So feedlot-raised animals, when tested, for example, at Iowa State University, have a preponderance of omega-6 fatty acids in the meat and the free range, a preponderance of omega-3. You can actually get omega-3 from beef if it happens to be a free range. There have been people on the planet of our particular species. Some of us think it's a misnamed species for Homo sapiens, considering what we sometimes do, for roughly 200,000 years, for what it looks like from the archaeological record. And for how many of those 200,000 years has agriculture been around, as far as we know? 5 to 10,000. And there are quite a number of us who really aren't adapted to agriculture. And when we eat even the best natural whole grains, our bodies can't deal with them yet. There's some of us who take a long, long time in our genetic heritage to adapt. It's been pointed out that the genetics which contribute to type 2 diabetes, and as Alan was pointing out, it's not all genetics, it's not all diet, a lot of it is toxicities. But it's been pointed out that the genetics that lead to type 2 diabetes are actually a positive survival benefit if you happen to be a hunter-gatherer or someone living away from the tropics. It's been demonstrated, particularly by Professor Yudkin, that people who have the genetics that might lead them to type 2 diabetes can put on weight on the same isocaloric and iso-everything diet 3 times more rapidly than people who don't have those genetics. And the ability to get fat fast was a really good idea when folks were wandering around looking for food. Food wasn't always abundant. People who couldn't get fat very fast and stayed skinny sometimes just didn't make it through the next winter. So now it's a selective disadvantage. I'm going to get off the native diet thing, though, and make a few of those comments on what Alan was talking about. For one, there are 2 studies I'm aware on eating a whole bunch of eggs. I'm going to get a few specifics here. In one study done in the 1980s, folks were asked to eat 3-4 dozen eggs a week for a number of weeks in a row. They had their serum cholesterols measured before and after. And in that particular study, 18% of the folks had their cholesterols go up, and the other 82% they didn't. Well, apparently someone didn't believe that because this study was repeated in the 1990s. They came out with almost exactly the same statistic. In this case, it was 21% had the cholesterol rise, and the other 79% did not. So apparently, you're in the 80% who does not have his cholesterol affected by eating eggs. Studies on all kinds of interesting things. Alan mentioned Dennis Burkitt and his pointing out about high fiber is good for us. You forgot his favorite quote, or at least it's my favorite quote of his, which is, the larger the stool, the smaller the hospital. And that's straight from Dennis Burkitt. I don't take any credit for that. Now, for those of you who are interested in Googling things, try this one. Aspartame fire ants. You've read about that? Article straight out of the Idaho Sentinel and Observer, I believe. A woman who found that if she just left aspartame around the fire ant hill, the fire ants ate it and died. And that the best way of keeping her house free of ants was to take packets of aspartame and empty them in the corners of the rooms. Aspartame is a wonderful ant killer. And when I talk to the people I'm working with about that, that's one of the things that will drive the consumption of aspartame down the quickest, is just letting people know that it has higher and greater uses than to sweeten their food. Alan mentioned the increase in consumption of fructose over the last, 20 years, since the early 1980s, from, 0.4 pounds per person per year to 62 pounds per person per year. Since I'm not eating any, that means there's some people out there eating 12 pounds per person per year. But I bet there isn't one person out there who could tell me why that happened. An act of Congress. No kidding. Now, the act of Congress was not that we shall all eat high fructose corn syrup. The act of Congress was putting a tariff on sucrose coming into this country to protect the sugarcane producers in Florida and Hawaii. And so actually, the effect of that tariff set the price of sucrose at roughly 19 to 20 cents a pound, where it's been ever since. And so the producers of high fructose corn syrup saw an opportunity. They can make it for a heck of a lot less than 20 cents a pound. And they did. So actually, among the very many other things our Congress is responsible for, Mark Twain is the one who not only said, "No man's life, liberty, or property are safe while the legislature is in session," but he's also the one who said Congress is aptly named as Congress is the opposite of progress. So if we can convince our Congress people to get the tariff off of sucrose, well, we probably still have all that high fructose corn syrup, but you know what we would also have? A lot easier time preserving the Everglades, because we know what happened to the Everglades. And most of that land has disappeared, has been taken up for sugarcane production, because domestic producers have this tariff to protect them. Things do get really mixed up, health, politics, and so on. All right. What I'm really supposed to be talking about, I think, are three things. So I'm going to be talking faster, as you can tell, because we don't have that much time to go. And that has to do with dysinsulinism, food allergy, digestion, and assimilation, but specifically gastric hypochlorhydria. I'm going to take this time place to deny that every patient who comes to our clinic gets a gastric analysis. It's only 50%. It's not everyone, but we do have that reputation, and I think deservedly so. Now, mainstream medicine, if we want to call it that, is finally waking up to hypochlorhydria, looking at what happens to people when they take proton pump inhibitors, antacids, and so forth over a prolonged period of time. Why, just very recently, one of Alan's favorite medical journals, AMA Journal, he likes to read that one because you can make so much fun of it.
Yeah, I called it the Paleolithic Journal of the AMA, and that's abbreviated PAJAMA.
Just informed us that prolonged use of proton pump inhibitors raises your risk of hip fracture. You all remember that? Wow. Okay. And actually, the AMA Journal has also told us that prolonged use of acid suppressant medications leads to, and this is in people who are not in hospitals, a significant increase in clostridial diarrhea. Whoa. Okay. And then here's another article that said in people, they're called community living because they want to say they're not in the hospital, who take proton pump inhibitors. Why, they get 2 to 3 times as much pneumonia as people who don't. And then you might have noticed in the age-related macular degeneration studies, that much to their puzzlement, they could not figure this one out. One of the positive risk factors was antacid use. So, interfering with stomach acid is going to mess with our lungs, our retini, our hips. Come on, guys, shutting off the digestion is bad for you. So they're noticing the lack of gastric acid has bad effects. But there's this other condition where one does not have to take a proton pump inhibitor, an antacid, or anything like that. It's called getting older. Are you doing that too? Well, I am. I've got to deal with Holly, my wife. I have all the gray hair in the family. She doesn't have to have any. So far, it's worked. We're keeping our fingers crossed. Back in the 1930s, teams from Johns Hopkins University and the Mayo Clinic, still fairly prestigious places in some quarters, published reports that said that by the time we all get to be 60, half of us, that's 50%, have enough of a functional decline in gastric acid output that we're not optimally digesting and assimilating the nutrients that are particularly dependent on acid and pepsin in the stomach. Now, that's just age-related, they said, and there's other things that are age-related. When Alan and I first started giving this lecture series in 1983, I didn't need these folks here. These ones. And Alan, he had more hair. And I can't run as fast as I used to, and I hope I can remember what I'm supposed to. You know how that goes. One of the things that comes with age is increasing decline in the digestion. Your stomach went out to lunch and left you behind. Now, certainly there are certain ailments that happen at much younger ages that are associated with gastric hypochlorhydria too. Those happen to include such things as childhood asthma and eczema, a whole variety of autoimmune diseases. 60% of the people we test who have MS are profoundly hypochlorhydric, and we'll cover that when we get to autoimmune diseases. But the point is, if you're working in anti-aging, it isn't all hormones, folks. A lot of it has to do with eating that good diet that we've been boring you to death with here. And secondly, getting that good diet digested and assimilated into the system. Here's another category of folks who come into the clinic who you can tell right away they don't have much acid down there. It's the women who come in and say, my fingernails, they're cracking, splitting, breaking, chipping, peeling, layering back. I'm a guy and I know all those terms. I've listened to enough women telling me about that, and I've started asking people about their nails, and I get these looks, what are you doing asking me about my fingernails? Alternatively, it's women who are having a lot of hair falling out. Actually, gastric hypochlorhydria has more to do with that than hypothyroidism does. Those are a couple of physical signs. Now, sorry about that, guys, but guy can be achlorhydric, his fingernails are going to be fine. I'm not sure why. It's very definitely different depending on gender. And of course, guys know about their hair falling out, and that doesn't necessarily have much to do with gastric hypochlorhydria. There are also symptoms: belching, bloating, indigestion, gastroesophageal reflux, constipation. When I eat meat, it feels like it sits in my stomach. All of those things are symptomatic of hypochlorhydria. However, my textbook of pharmacology from 1941 says a significant minority of people who are totally achlorhydric have no symptoms at all. So one has to watch out for that too. One of the simpler ways of watching out for that is doing that much reviled thing called a hair mineral analysis. Those really do get criticized, but if you get hair mineral analyses and the majority of the beneficial minerals are way lower than median, probably somebody with hypochlorhydria. The alternative is hidden gluten sensitivity, but hypochlorhydria is responsible for that over and over and over again. The variety of nutrients that do not digest/assimilate well if we're hypochlorhydric is a very wide one. Let's take all 8 essential amino acids. I've learned to run amino acid analyses of the essential amino acid analysis on just about anybody who's hypochlorhydric. We usually have anywhere from 3 to all 8 of them low, the essential amino acids. And the only thing that throws a curve into that test, and excuse me, Alan and I have this little argument about testing people. I like to do a few more tests. He likes to do a lot less tests. So, okay, fine. Everybody has their own practice style. The only thing that can throw a curveball into that is if you happen to see essential amino acid analysis where, there's 3 or 4 that are low and there's 2 or 3 that are high. And what's going on here? What's going on here is insulin resistance. That's also almost pathognomonic for somebody with insulin resistance, is a pattern of a few high essential amino acids and a few low ones too on the same test. So one can tell sometimes from the amino acid analysis and the hair analysis that the person is hypochlorhydric. Okay, so there's all 8 essential amino acids. Then practically any mineral that isn't monovalent: calcium, magnesium, zinc, copper, chromium, vanadium, etc. And that exempts sodium, potassium, lithium, and the halides, fluorine, chlorine, bromine on the other end. They don't care if we got acid down there. So how many essential minerals are there? There's some argument, but probably between 12 and 15 that we know about right now. And then we got 8 essential amino acids, any one or more of which we might not assimilate well. And then B12 and folic acid, and what did I leave off? Is that about it? Yeah, I think that's about it. So if we add up the total number of nutrients that might or might not be absorbed well, it adds up to over 20 essential nutrients. My goodness, there's only 55 to 65, depending on who you believe. I'm not at all trying to say that a person who's hypochlorhydric is going to malabsorb all of them. No, it's always a variable pattern. It's as if you handed the person 8 darts and told them to throw at a dartboard with 25 different targets. You don't know what they're going to come up with. But if you're working in anti-aging, be very, very aware, please. You got to look at digestion and assimilation of those nutrients. If we try putting in hormones and the person is missing 8 or 9 vital nutrients, we're actually driving a car that's got faulty brakes, and we're driving it faster, that is. It's got faulty brakes and a little knock in the engine and some transmission trouble. It's just going to break down sooner if all the nutrients aren't there to support the well-being and the other increases a person wants to do when they're taking hormone replacement therapy. We happen to use gastric analysis by radiotelemetry. It's called the Heidelberg Capsule Machine. No, I don't work for that company and they don't pay me anything. At the present time, that's the most accurate way we've found to diagnose it. And please, dropping a piece of pH paper or something like that down the stomach and measuring it and telling everybody they're okay, that's not the way to do it. It really does require a measurement of acidity, a challenge with alkalinity, another measurement, another challenge. And as Alan just pointed out, because I should go faster, this is described on pages 139 and 140 of your book there, including the testing. I'll get to treatment last. Treatment is very much like replacing hormones, except it's replacing hydrochloric acid with pepsin. There are several different companies that sell betaine hydrochloride. Betaine is a carrier for the hydrochloric acid. And once it gets wet, it dissociates. And not only do we get the hydrochloric acid, we get a betaine supplement. And it has pepsin in it. Now, Al and I have a small disagreement about how much hydrochloric acid and pepsin should be used for each person. Not a very large one. For adults, no kidding, I'm routinely recommending 5 to 6 capsules with a full meal, 3 to 4 with smaller meals. Alan's a little further down the scale on that. I came to that by observing the results on such things as mineral analyses and essential amino acid tests, and that's what it would take to help people gradually bring themselves up to normal. When things are bad enough, we do nutrient repletion by intravenous administration for a few weeks, and then if a person's fully built up on their digestive aids, they can usually maintain once they've been repleted. If I'm working with a person doing a physical exam and I happen to see a bunch of skin tags or even just one skin tag, up goes the index of suspicion that this person is at least insulin resistant, maybe type 2 diabetic. Now, where the heck did that come from? No kidding. There are 3 studies out there where folks have counted skin tags, looked at people without skin tags, done large enough groups to show that there is a positive correlation between little tags of skin under your arms, in the groin, on the neck, and the tendency towards type 2 diabetes. Now, their studies are old enough that they were talking about type 2 diabetes at the time. Now, those tags are supposed to be caused by a little virus, a verruca, isn't it? Somebody like that? But there must be something about that virus that likes the metabolism of people who tend towards type 2 diabetes and dysinsulinism. Now, there are a lot of other clues. We've all heard of the metabolic syndrome, insulin resistance, first described by a very, very mainstream professor, Gerald Reaven, out of Stanford. But I continue to be frustrated, and I'm pretty sure you do too in practice, when in comes a new patient and they're taking, what do we got here? Diuretics and beta blockers for their hypertension. And over here, they're taking a statin because their cholesterol goes too high. Oh, and by the way, have they been advised on diet? Probably not. Okay, and so I have to spend my time, as you do, explaining to folks that, gee, if you've got this thing called insulin resistance to the metabolic syndrome, what you've got is a genetic capability of over-secreting insulin as compared to people who don't have this genetic tendency in response to carbohydrate intake. And that was proven by Professor Yudkin in the study he did at, it was either Oxford or Cambridge, I forget which, where he advertised for graduate students. You know, graduate students will do anything for money that's legal. You've been a graduate student? And so they got paid to all live in the same dormitory, and everybody ate the same food, which included 14 ounces of sucrose. Some of those grad students had to be able to show all the way back several generations that there was absolutely no diabetes of any sort in their families. And the others had to be able to prove beyond a doubt that, yes, there was type 2 diabetes in their families. And those were the 2 different groups. And what Professor Yudkin measured was serum insulin, serum cholesterol, serum triglycerides, blood pressure, and weight. And then everybody ate that same diet. And after 30 days, there was significant increase in all parameters among the grad students in their 20s who had type 2 diabetes in their family. They had higher serum insulin, significant over the grad students who didn't. They had higher blood pressure. They had higher cholesterol. They had higher triglycerides. This was statistically significantly higher. And the students who had type 2 diabetes in their family had gained 9 pounds. And the students who had no type 2 diabetes in their family had gained 3 pounds. Well, if we make more insulin than our neighbors over here in response to sugar, after a while, our cells are going to get very tired of that. Now remember, 60,000 years ago was a selective advantage. Let's see, we're coming into August, September, October, and the fruit is on the trees and the berries are on the vine, and you could do poetry with this. And so we chow down on all that and we gain weight rapidly so we can get through the cold winter time when there isn't much food around. And the people who don't gain that weight, they're more likely to die off, particularly if there isn't any food in the springtime either. But when there is enough food around, even if it's a low quality and packed full of carbs, our pancreases are making insulin all the time, not on a seasonal basis. And after a while, the cells get tired of that, and somehow insulin resistance happens. I don't think the mechanism of that is worked out. How do you make insulin resistance? So we become resistant to that insulin. And so just like a little kid whose dad yells at it all the time, they kind of get deaf and dad has to yell louder. And then the little kid pays attention. And then, well, now they're accustomed to that. So you have to yell at them even louder if you're a yeller. I had a dad like that and I tuned out a lot. Anyway, the cells of the body just tune out. And so the body has to make more and more insulin. And where are we going with that? HMG-CoA reductase, the enzyme, its final enzyme in churning out cholesterol, is depressed by statins. And what's it triggered by? Insulin. So I tell folks, you can either put a lid on the pot that's boiling over with the statins, or you can turn off the stove. Now, which one makes more sense, turning off the stove or putting a lid on the pot that's boiling over? Why turning off the stove? All right. That's why ordinarily I recommend to folks with dysinsulinism, type 2 diabetes, the Richard K. Bernstein type of diets. You've heard those, you've seen them. Poor man was an engineer who found that the conventional treatment of diabetes wasn't working for his diabetes. And he developed the same thing that Bob Atkins developed, the high protein, low carbohydrate approach. Look up his books, Richard K. Bernstein. I think they're amongst the best in the field. Got his diabetes under wonderful control, started giving lectures about it. He wasn't an MD, nobody would respect him. So he went to medical school at age 42, graduated in his 40s. He's now what I would consider to be one of the experts on diabetes control. That's why, again, I have most folks cut their carbs way back. I'm not in favor of no carbs. I don't think any of us are, but cut them way back so that we can settle down that insulin response. And if we don't have all that insulin response coming out, our insulin resistance is going to fade away too. Now, we'll be talking more about specific nutrients that can help in that job. That's just a general thing. All right. That's the second general area. If 1 out of 3 people, according to medical anthropologists in North America, has the tendency toward type 2 diabetes, and all those folks who you're not counseling with are out there eating all that junk with all those carbs and all that sugar, and no wonder it's such a big thing, and no wonder we see so many people in our offices with that. Again, half of us by age 60 are going to get to hypochlorhydric. That's a fairly big deal. 1/3 of the population is prone to type 2 diabetes. That's another reason why Alan put these topics up front. And then I'll cover the third one, namely food allergy. That's a very big one. For those who haven't seen James Brenneman's Basics of Food Allergy, go to your favorite used book online search engine. My favorite happens to be usebooksearch.co.uk. It's from England. It covers all the other used book searches, and it's more likely to turn up a used book, in my experience, than most of these search engines out there. Brenneman was, at the time he wrote the book, chairman of the Food Allergy Committee of the American College of Allergists. Woo, what a credential. Now they call themselves the American Academy of Allergy and Immunology, but it's the same outfit. Brenneman wrote in the preface to his book that in his experience, over 50% of all undiagnosed symptoms. Now, he did not say over 50% of all disease. I want to be real clear on that. But he did say that if somebody wanders into your office with undiagnosed symptoms, maybe somebody's called them a disease, maybe they haven't, but we don't know what their symptoms are about. His claim was that over 50% were due to one or another reactivity to a food. All right, I read his book shortly after it came out in 1981, started checking on that, and damn, the man was right. He linked food allergy with all kinds of interesting things. One of my favorites, which we'll cover later, is a 100% correlation with cholecystitis. I didn't say gallstones. I did say cholecystitis, inflammation of the gallbladder. The list of things that are food allergy attributable is very, very long, goes all the way from migraines to arthritis to many, many things we would never suspect. I think we've got that listed in the back too, do we not?
We have a handout. You can find it in the index under food allergy. We have an elimination diet protocol that I used in my practice that tells you how to eliminate and re-challenge foods. We'll discuss that later on. Also, there's a long list of conditions that are related to food allergy.
Right. So please do be looking for that. Now, this is another, as far as we know, another relatively modern manifestation. The word allergy wasn't even made up until what, 1904? Something like that. Somebody named von Perquet. I guess you have to learn that stuff if you're going to talk about it. But the first instances of allergy published in relatively modern medical journals happened to be in the Lancet in the early 1800s. And when one goes back and looks at where the doctors were who were reporting those and where the patients were, they weren't in, oddly enough, but they ringed at the cities of Manchester and Liverpool, which were the first cities to industrialize and start putting all kinds of coal, what are the products of coal combustion? Coal tars? Yeah, anyway, putting out a lot of industrial pollution. So there is some thought. Yes, it's known that asthma is written in ancient medical papyri, but nobody ever heard of, I'm getting over here now to what's commonly called hay fever and inhalant allergy, other than asthma, before that came out. And it appears that the large increase in noticing food allergy is due to a couple things. Once again, a lot of skewed body processes because of pollutants. And then secondly, going back in human history, to just the changes in what food we're eating. Remember, till 10,000 years ago, wheat in its common form just wasn't around. And nobody was eating soy. Soy is very, very much an agricultural product. So please do look out for allergies. Look out for dysinsulinism. Look for digestion and assimilative problems. And that's about the last of the generalities we're going to throw at you. I'm sorry I had to go so fast here, but I think Alan has 2 or 3 announcements to make.
And we'll go over these aspects in more detail many times during the conference because they're so integral to nutritional medicine. First of all, I forgot to mention at the start, I'm ahead 1-0 right now. I made a bet with Jonathan that I would quote Bob Dylan fewer times than he would complain about the government. So I'm up 1-0 right now, and I just wanted to tell him that you really shouldn't complain about the government because, as Bob Dylan said, it's life and life only.
As a representative of the sucrose manufacturers, I wasn't complaining.
There is a handout in the loose leaf binder, pages 141 to 146, that describes the elimination and re-challenge diet that I used in my practice with approximately 3,000 patients over a 19-year period. And it's not perfect, but I found it very useful for detecting the most common allergens in a way that people can identify them and be convinced that they need to get them out of their diet.
And that's where Alan's famous okra and yak fat diet comes from. He has people just start with those 2 because he figures nobody's allergic and then add things back in. Isn't that the way you do it?
Right. Actually, it eliminates wheat, corn, dairy, citrus, coffee, tea, alcohol, and food additives. And it's not really as hard as it sounds. We had a staff member on site who spent a half hour to an hour, whatever was necessary, to teach the person how to do elimination and rechallenge. The nature of the food allergy that we're talking about has been called masked or hidden allergy. It's not the kind where you swallow a peanut or a strawberry and you can't breathe. That's an obvious IgE-mediated reaction. We don't completely understand the biochemistry of how these other reactions occur, but we know clinically that they do. And if you look in the spiral-bound citation manual, you will find probably in the hundreds of articles, most of them clinical observation studies, a few of them double-blind placebo-controlled. It's hard to do a placebo-controlled challenge with food, but they do it with an opaque capsule with a food extract. And they've demonstrated, in my belief system, beyond reasonable doubt, that food allergy is a common cause of problems. So this is one way that we do it, and Jonathan does some testing. Do you want to talk about that now or later?
Just real briefly, we do two types of testing. I'm sure you're mostly familiar with them. One of them is the ELISA assay, just drawing blood and looking for IgG and IgE antibodies. Of course, any textbook will tell you that that's one of only 4 major ways of being allergic, namely having antibodies. So it doesn't pick up everything that the person may be sensitive to, in my opinion. The other one we use is the EAV, electroacupuncture according to Vol, and that one is quite controversial, especially with state medical boards. However, if one is working with a technician who knows what he or she is doing, I found it really, really useful at unraveling some of the toughest problems.
So the first thing you do is you suspect the allergy, and that may be if someone has a childhood history of recurrent ear infections, growing pains, all the list that's on the slides and on the handout, page 141 and beyond. And the way I do it, I try to unmask the allergies by making them very sensitive. You clear out all the common allergens, and within a few days they get withdrawal symptoms. The withdrawal symptoms then go away, and the patient begins to feel much better. After that, they become exquisitely sensitive. They get an overreaction and a rapid reaction when they challenge themselves with individual foods. Many of you already know about this, and it's written in detail here. We can take questions about this at the various question and answer periods, and I'll be happy to answer very specific questions about this by email after the conference. If you read this and study it and have specific questions, we'll be happy to answer them, since we're not going to spend an enormous amount of time on how to do this. What I can say is that if you don't look at food allergy in your practice, you're going to be missing, as Jonathan said, maybe 50% of the symptoms that you're trying to help. And if you do it, you'll be one of the many people that when you go to a conference, and I asked for a show of hands, how many people routinely hear from your patients that they've been to 17 other doctors and you're the first person that's helped us? And when I go to a naturopathic conference, everybody in the room raises their hand. Or if I go to American Holistic Medical Association or ACAM, everybody raises their hand. I think they're all telling the truth. So we're going to begin now with the individual nutrients. We're not going to spend a great deal of detail on the specific clinical indications if we have them discussed in the protocols later on. The last 2 days of the conference, we will be discussing specific diseases like congestive heart failure and migraines and Crohn's disease, etc. And we will talk about the specific interventions that we use. So, for example, if we say now that vitamin A has been used for inflammatory bowel disease with some success, we're just going to say that and then go on to the next thing and then discuss it in more detail in a couple days. The main points that we want to touch on with the individual nutrients and herbs and hormones is how to use them, what doses to use, what they interact with, what the toxicities are, and what the main clinical indications are without necessarily any detail.
However, even though we're going to be spending more time on the conditions as much as we can, we want to start with the toolkit first. Once the person learns the toolkit, then it can be applied to conditions which aren't even in this book. Just for example, a very brief example, Alan, choline. Now, choline is, of course, a precursor of acetylcholine. Everybody knows that. We'll have some illustrations later on where, working with that, you can deal, at least partially, with symptoms that are not printed anywhere, such as lower esophageal sphincter malfunction and myasthenia gravis, just by knowing what the tools do. So it is a really good idea to, even if we skip over these lightly, If you have the time when you're at home, take a look at each of the tools. Where does it go? And pretty soon you'll be getting creative about what you can do with those tools that aren't in our book or anybody else's.
Yeah, so Jonathan basically invented a therapy for myasthenia gravis based on the idea that he wanted to increase acetylcholine levels, and he used choline as a precursor and the various cofactors that are known to be involved in the synthesis of acetylcholine. And you've treated some patients and they got better? And I did some things with pantethine with that, which we'll discuss when we get to that. Okay, so we'll start with vitamin A, and that's on page 2 of the salmon-colored loose leaf. Vitamin A was the first vitamin discovered. That's why they named it A. And they discovered very early on that it was the so-called anti-infection vitamin. When they made animals deficient in vitamin A, they got pneumonia and other infectious diseases. And since then, it's enjoyed a good reputation for being useful for fighting various kinds of infections. It also promotes the integrity of epithelial lining, which includes skin, gastrointestinal tract, conjunctiva, and respiratory tract. So you'll see that some of the main clinical indications are related to those specific tissues. And it also enhances immune function, which helps fight infection. So the clinical indications, various types of infection. We use large doses clinically. This has not really been studied so much in research, but anecdotally we find that if you use like 100 or 200 or 300,000 units of vitamin A per day, and sometimes we add vitamin E with that because it enhances the activity of vitamin A, people seem to get over their acute colds or their pneumonia or their other infections much more quickly. So this is a clinical use that we find is valuable. For enhancing immune function with HIV, they've discovered that women who supplement with 25,000 units of vitamin A during pregnancy are less likely to transmit the virus to their baby during birth or afterwards. So this is one thing that has been documented, and we'll discuss the concerns about using vitamin A during pregnancy, because here's where the issue actually comes up. There's very few other reasons why you would consider using high-dose vitamin A during pregnancy. Menorrhagia, there's an uncontrolled trial that's extremely successful. 92% of women with excessive menstrual bleeding had either complete normalization or improvement by taking vitamin A supplementation. Now, how does that work? We're not sure. It may have to do with estrogen metabolism.
If you look deep into the textbooks, you'll find that vitamin A is absolutely necessary for steroidogenesis in general. Not just estrogens, but just about any steroid molecule has to be manufactured, has to have a basic amount of vitamin A.
Vitamin A has also been used to treat or prevent peptic ulcers. There are situations in the hospital, trauma victims or people under severe stress due to critical illness. There's a 60-some% incidence of what they call curling ulcers. That's a gastric ulcer induced by stress. And if they give vitamin A by injection for 3 days, it greatly reduces the incidence. So vitamin A here probably works by improving the epithelial barrier.
The doc who studied that found that as soon as the individual who was severely stressed could start eating again, that the need for injectable vitamin A went away. And tracking that even deeper, found that a protein that carries vitamin A around the bloodstream, transport protein for vitamin A, is not released when a person is fasting. And of course, severely stressed people are usually very perhaps unconscious. They can't eat anyway. They're put onto IVs. And that's why when they started eating, they no longer needed the intravenous vitamin A, because the carrier protein emerged from the liver. But that's why they had to have the IV when they're unconscious and not eating, in order to maintain those epithelial surfaces that ordinarily would be maintained just fine with all the vitamin A stored in the liver, which wasn't coming out.
Another good use for vitamin A, this will come up a lot in your practice, the dry eye syndrome, also called the Sicca syndrome, S-I-C-C-A. According to some uncontrolled trials, which were admittedly funded by the company that sells the product, there was a very high success rate in correcting the dry eye syndrome. In my own experience using their product, which is listed here in the book, it's Viva Eye Drops, and we have the 800 number where you can get it. It's a kind of an oily solution that you put in your eyes. About half of the people with chronic dry eyes are very happy that they use this stuff. They take it periodically after the first month as needed, in my experience. Chalazion, which is like a sty, but it's different. It's a little bump that occurs on the eye due to inflammation. And if you catch it early, you can knock it out using high-dose vitamin A, according to one report. Night blindness or impaired dark adaptation is a well-known manifestation of vitamin A deficiency. and so we won't go into that. Allergic or viral conjunctivitis, we'll talk about this more under the vitamin C section, because it's really the vitamin C is probably the main active ingredient. Skin is an epithelial tissue, and there are numerous skin diseases that improve with vitamin A supplementation, often in very high doses, but not necessarily. Acne, we'll talk about that more detail later. Very high doses of vitamin A have been shown to clear up the severe cystic acne in people that are candidates for Accutane. It doesn't work as well as Accutane, but it can be used in a way that's safer than using Accutane. We'll go over that later. Prevention of sunburn. If somebody needs to have a melanoma-inducing dose of sun for some reason, you can apparently prevent them from getting sunburn by using the vitamin A here. The mechanism of action is not known. Maybe it prevents oxidative damage in the skin. There are some less common diseases. Darier's disease, which is rare. They use enormous doses of vitamin A, and this is actually in some of the dermatology textbooks. It's one of the few treatments that has actually been shown to improve this condition. Ichthyosis, which is a chronic fish scale type skin. There are many cases that don't respond to anything, but there are some that respond to high dose vitamin A, some that respond actually to B12 injections, and we have no idea why, but that's been mentioned in the literature too. Eczema, probably more of a supportive aspect in the treatment of eczema. Anytime there's a chronic skin condition, it's worth considering the use of vitamin A because it promotes the healing of the tissue regardless of what the cause of the problem is. So we use other things mainly for eczema, and we might add vitamin A as an enhancement to the healing. And then just generally enhancing tissue integrity, as Jonathan mentioned, if you come across a disease that has to do with some epithelial lining, consider adding some vitamin A as general nutritional support. Kidney stone prevention may or may not apply in this country. There are parts of the world where severe vitamin A deficiency occurs, and they actually get severe and permanent eye damage from vitamin A deficiency. It's that bad. And in those areas, particularly in India, there's epidemic kidney stones that occur that appear to be due to vitamin A deficiency. So if you have a patient who's consuming an erratic or otherwise deficient diet, they're not getting any carotenoids in their diet, you might consider vitamin A supplementation, because as you know, carotenoids are the precursor to vitamin A.
But they won't precurse into vitamin A unless there's enough thyroid around. It's the thyroid helps to cleave the carotenoid into the vitamin A.
Okay, now how much vitamin A do we use? The typical diet probably contains just a couple thousand units. And most of the vitamins these days have taken vitamin A out and they've put in beta-carotene instead. You cannot get a medicinal effect of vitamin A by using beta-carotene. It's maybe 5,000 units a day you can manufacture in that range of vitamin A from beta-carotene. After that, it saturates and just the carotenoids build up in the skin and your skin turns yellow, but you don't get any more vitamin A. So if you're looking to use 100,000 or 200 or 300,000 units of vitamin A for short term for a medical condition, use the preformed vitamin A. Now it should be noted that preliminary research has shown that the oil-soluble form of vitamin A is much less well absorbed than the water-soluble form. So both the effectiveness and the toxicity are significantly greater with the water-soluble forms. Now, I cannot give you an exact dosage comparison right now. We did put some preliminary data in here on the next page as far as a guesstimate on how much you should use if you're using which ones, but it's really up for grabs right now. We don't really know because some of the studies didn't necessarily specify what kind they were using, but just be aware, err on the side of lower doses if you're using water-soluble, and you can consider higher doses if you're using the oil-soluble form of vitamin A.
But the side effects of too much vitamin A are fairly obvious. They amount to increased intracranial pressure and headache, pain in the long bones, dryness of the skin, cracking of the lips, and so forth. So if I'm having someone push the vitamin A for a therapeutic reason, I write all the possible bad effects out, and then those people who've noticed them and promptly drop the vitamin A have always had all those symptoms go away and go into remission. So killing somebody without them knowing it's the vitamin A is fairly difficult.
Yeah. That's true. However, there have been two cautions that have been noted about vitamin A. Both of those I'm not entirely convinced should be taken seriously. I'll deal first with the issue of causing birth defects. There is an observational study where more than 10,000 units a day during pregnancy cause birth defects in the heart and elsewhere. However, a follow-up study done in a different part of the country, in Oakland, compared with Boston in the first study, showed that even higher doses of vitamin A, up to 40,000 units during pregnancy, were associated with a 50% reduction in those same birth defects. So that's epidemiology for you. I've come up with a hypothesis on why Boston gets birth defects and Oakland does not. It's what you might call confounding by indication. Why do people take vitamin A in Boston? Maybe because it's cold and there's no vitamin D there and they're getting sick all the time, so they read that vitamin A is good for you if you get a cold. So maybe it's people who get colds are at more risk for birth defects, and it has nothing to do with the vitamin A. In Oakland, California, on the other hand, it's not that cold, and maybe people take vitamin A for their acne. I mean, this is the problem with epidemiological studies. However, we are dealing with little fetuses that could turn out with deformed hearts, so we want to err on the side of caution. And for that reason, I would concur that in the absence of any additional information, there's very little reason to give high-dose vitamin A during pregnancy, with the exception of going up to 25,000 units for HIV-infected mothers. The other point that's been put out is that minuscule doses of vitamin A or higher promote the risk of osteoporosis and increase the risk of hip fracture. And this makes no biological sense to me, because we're talking about the amount of vitamin A that you would get merely from thinking about a piece of liver, or eating a little piece of spinach and getting a little trickle down to vitamin A, like 2,500 or 5,000 units of vitamin A. Above that, more risk of bone problems. Biologically, you can't do that in animals. You have to give animals on the order of about 1 million units a day for a period of time to cause bone disease. And in animal research studies, they use 25,000 units a day, human equivalent, per 70 kilograms of body weight, 25,000 units as the control group, and they never get any problems with them. So I think these observational studies are confounded by something, and I submit that the confounding is the fact that vitamin A in the human diet currently, or in the American diet, comes primarily from vitamin A fortified sugary cereals, vitamin A fortified trans fatty acid containing margarine, liver, which is unfortunately infested with pesticides and other stuff, and butter and milk. Milk, which may or may not prevent osteoporosis. There's actually some observational studies that say milk does not prevent osteoporosis or fractures. So what I think is going on here is that vitamin A in low doses does not cause osteoporosis, and if you have a clinical reason to use it, don't let that observational study scare you. Okay, comments on A? All right, carotenoids. It's in the vitamin A category. You've got beta-carotene, which is well known, and then other related chemicals, lutein, zeaxanthin, and lycopene we'll talk about as well. Beta-carotene is present in a wide range of fruits and vegetables, and observational studies have shown conclusively that high intake of carotenoids is associated with less heart disease and cancer. And then clinical trials, placebo-controlled double-blind trials, have shown almost the opposite, that high-dose beta-carotene, or even moderate-dose beta-carotene in cigarette smokers increases the risk of lung cancer by 20 to 30%. So it's hard to know exactly what this means. It could mean that you don't want to just supplement with an individual carotenoid because you'll unbalance other things. It may mean that the trans beta-carotene, which is what they sell people to put in capsules, which is not the same as the part trans and part cis that you get in food, is improperly balanced and may cause some problems, just like the vitamin E alpha-gamma tocopherol might be causing some problems. Another possibility is that beta-carotene has a toxic interaction with cigarette smoke. And I tend to lean towards that last one. Maybe the other ones are true too, but they have shown a similar reaction with animals given massive amounts of alcohol, ethanol. If you try to damage an animal's liver with ethanol, you can do a much better job of damaging the liver by giving them a beta-carotene supplement too. So there is a toxic interaction with alcohol and beta-carotene, and I suspect maybe there's a toxic interaction with cigarette smoke. They have shown in one observational study that non-smokers who supplement with beta-carotene have a reduced risk of cancer of many types, and smokers who supplement with beta-carotene have an increased risk. So although there are problems with epidemiology, that is consistent with the idea of a toxic interaction. So what do we do with beta-carotene? There are some photosensitivity skin diseases that we can use it for, one called erythropoietic, love that, poetic, porphyria, 300,000 units a day massive amounts, and somehow it prevents the skin from erupting. Also, oral leukoplakia, which is a precancerous oral lesion that occurs either in cigarette smokers or in betel nut chewers, and sometimes it occurs in elderly people for no apparent reason. Beta carotene with or without preformed vitamin A has been shown to induce regression and prevent recurrences in some of those cases. Other than that, there's not a whole lot of reason to use individual beta carotene, and we caution people, if they are cigarette smokers, they should not take synthetic beta carotene, or if they're beta carotene takers, they should not smoke. There's one report on heavy carrot juice users developing amenorrhea, and when they cut down their total vegetable intake, their menstrual periods normalized again. It was not due to meat deficiency, because many of these people did not go on an omnivorous diet. They continued as a vegetarian, but just cut down their carotenoid intake. We don't know whether the beta carotene caused that, but that's just a clinical pearl. If somebody comes in with yellowish skin and no menstrual periods, ask them if they drink carrot juice and their other vegetable carotenoid intake, and try to reduce that, and you'll find in many cases their menstrual periods will come back. The other main carotenoids that have been studied are lycopene and lutein. Lycopene is present in tomatoes mainly, also in pink grapefruit and watermelon. It has antioxidant activity. It seems to protect the skin from sunlight-induced damage. Lycopene is the first antioxidant to go when the ultraviolet rays hit the skin. So if you have a lot of lycopene in your diet, you may be protected against sunburn and possibly against melanoma. That's theoretical, but certainly plausible. There are numerous observational studies showing that people who consume tomato sauce or other sources of lycopene have a markedly reduced risk of prostate cancer compared with people who don't have much of that in their diet. There are some intervention studies recently on using 15 or 30 milligrams of lycopene. Is usually in the form of a tomato complex. The most commonly used product is called lycomato. It's imported from Israel, and they have found evidence of regression or halting of the progression of prostate cancer over a short time period. Usually they are waiting for surgery, and they look at the tissue that they take out after the surgery, and they find out that the ones that took the stuff have significantly better tissue status than those who did not take the lycopene. So early evidence suggests that lycopene may be useful for prevention and therapy of prostate cancer. In this situation, more is not necessarily better, because there's one study using 90 milligrams, I believe it was, and there was no evidence of benefit and some evidence of possible increased progression. Again, perhaps the imbalance with the carotenoids from using a megadose of 1. Other than that, lycopene appears to be fairly safe, and there are no other obvious clinical indications. Lutein and zeaxanthin are the other main carotenoids that we've seen studied. Lutein and zeaxanthin are yellowish pigments, and they accumulate in the so-called macula lutea. I guess it comes because it's a yellowish pigment in the eye. That's where they named lutein from. Anyway, there's this thing called the macular pigment, and the thicker the pigment is, the more protected you are against macular degeneration. And they've shown that if you supplement with either lutein or zeaxanthin, most of the studies have been done with lutein, you can increase the thickness of the macular pigment. And why is the macular pigment good to prevent macular degeneration? Because if you remember your spectrum, yellow filters out blue, so there's a toxic portion of the sunlight's rays in the spectrum: red, orange, yellow, blue, green, indigo, violet. Blue is toxic to the retina, so nature has elaborated this mechanism whereby we accumulate this yellow pigment and it filters out the toxic blue light, and the thicker the pigment is, the better it filters it out. So they've shown the thicker your pigment, the less risk of macular degeneration. The more spinach and kale you eat, the less macular degeneration. Those are the main vegetable sources of this. Therefore, a lot of people are interested in supplementing with this. There's no known toxicity that I'm aware of. Lutein is mainly used. Zeaxanthin seems to have a similar effect. And because both of them occur in food, it's probably wisest to use a little bit of each of them if you're going to be taking a supplement. Okay, thiamine, vitamin B1, that's well known as something that you give to alcoholics when they come into the emergency room, because if you hook them up to IV glucose, you increase their need for thiamine, and you can precipitate an acute crisis. People can die from Wernicke's encephalopathy. They can get an arrhythmia. They always say give them an IM thiamine injection first before you give them the glucose. So that's the best known indication for thiamine. It's also known that you can get beriberi with severely deficient diets. In modern society, the two main places where people can get beriberi is with gastric stapling. People greatly reduce their food intake after that, and their stomachs are the size of a thimble. And some people get post-operative complications with vomiting and anorexia. And there are case reports in the literature of irreversible brain and peripheral nervous system abnormalities occurring shortly after one of these operations due to acute and unrecognized thiamine deficiency. The other time that it can occur is with women that have severe vomiting during pregnancy, hyperemesis gravidarum. So you need to be tuned in to the possibility that beriberi can occur, and it can occur rapidly. There is not a lot of store of thiamine in the body. It doesn't take more than a couple weeks of vomiting and anorexia to get beriberi, and therefore any way you can get this nutrient into somebody if they're not eating would be important. Maybe once a week, 50 milligrams IM if somebody's in a real bad situation. Other than that, thiamine has a couple clinical indications. We know that people with heart failure tend to be deficient, and heart failure is one of the manifestations of beriberi. So thiamine deficiency may be a secondary factor in heart failure, and it may be an adjunctive treatment with some benefit in some cases. Anecdotal reports for fibrocystic breast disease, we'll go over that later. Also, post-operative. I know Jonathan has coined the phrase, all IV bottles should be yellow. Would you like to amplify on that at this time?
If anybody's got an IV bottle up, they've probably been stressed, right? And yellow is simply riboflavin, of course, is always put in with B complex. If somebody's stressed, shouldn't they have the anti-stress group of vitamins in their IV? B complex, vitamin C. I think that should be routine. Sooner or later, we need to turn it into a scandal that all of our hospitals are using see-through IVs rather than at least translucent yellow IVs for stressed patients. There's only a few reasons I can think of not to do that. This stuff doesn't mess with any drugs they'd like to use. If you want to throw up a few drugs, the vitamin C and B complex will probably mitigate against some of the damage that the things cause.
Well, I've seen family and friends when I go to the hospital still that they hang glucose or saline. It's much worse with glucose because it increases the need for thiamine, and they don't put anything else in there. And they say, well, they're not going to be deficient. But you can get acute post-operative delirium, particularly elderly people. They've looked at hip fracture patients. It's a very common problem, post-operative psychosis. And according to one group, thiamine deficiency is a common cause of that problem. So for that reason alone, whenever we hang an IV, we should put all the B vitamins in there. Okay, so dosage and administration. The dosages range anywhere from 5 or 10 milligrams up into the hundreds, and we'll talk about that as we talk about the clinical conditions. There are a few potential interactions, none of them of great clinical importance in most situations. In the treatment of hyperactivity, some people have played around with high doses of individual B vitamins, and sometimes one makes them better and the other makes them worse, and so you have to do some experimenting there. The only major concern, and it's extremely rare, is there have been some fatal anaphylactic reactions, not just with intravenous, but there have been some with intramuscular and rare cases with oral thiamine too. So whenever you're prescribing anything by any route, be ready to deal with the consequences. But in particular, since it's best known by the IV route, be in a position, if you're giving IV B vitamins, to bring somebody out of an anaphylactic reaction.
I work with a number of folks from Alaska who come down to Seattle for this and that, drop in to see the doctor occasionally. They tell me that thiamine is one of the best ways to keep Alaskan mosquitoes from biting Alaskans. No kidding. A health food store owner from Fairbanks tells me that she's sold out during hunting season until she learned to stock enough. It's a sulfur-containing amino acid, and apparently if a person takes half a gram to a gram of thiamine before going to visit the mosquito-infested swamp, the mosquitoes just simply don't prefer the people with the thiamine in their sweat.
So just to allay your concern some, the incidence of anaphylactic reactions is on the order of 1 per couple million vials purchased, according to the British observations. Okay, riboflavin, and we're going to go through these individually fairly quickly because in most cases we use B complex and then sometimes we add individual nutrients on top of that. But I almost always use a B complex to support a high dose of an individual B vitamin. It just seems reasonable to do, and we don't know for sure that it's necessary, but it certainly won't do any harm. Riboflavin is a cofactor for FAD, flavine adenine dinucleotide, and that's in the electron transport chain where energy is produced in the mitochondria. So anytime you look at a condition that's associated with impaired energy production, heart disease, migraines, chronic fatigue, you want to crank up any of the biochemical pathways. You want to consider cranking them up in any way you can. Jonathan will talk about niacinamide, which can do that later on, magnesium and others. So they've looked at migraine patients and they found that they have impaired ATP production. So they did some controlled studies with high-dose riboflavin, and lo and behold, 30 or 40% reduction in migraine recurrences. And then I found out later on that 50 years ago, some people said the same thing using 15 milligrams of riboflavin instead of the 400 that they were using today. So I tend to go with the lower doses since you don't have to worry about toxicity, and it seems to be effective. A recent study compared 25 milligrams of riboflavin to 400 milligrams plus magnesium and feverfew altogether, and the low-dose riboflavin worked just as well. So why worry about megadoses in that situation? There was a case report or two on phenothiazine-induced psychosis. And phenothiazines are supposed to treat psychosis, and there's some people who actually became psychotic after they'd been on these. Phenothiazines are structurally very similar to riboflavin, and they gave them riboflavin, and their psychosis that was induced by the drug resolved. Also, some preliminary work on the treatment of Parkinson's disease, and we'll discuss that later on. Riboflavin is generally safe, except I have a little bit of free-floating anxiety about the use of that in very high doses because riboflavin is a photosensitizer. They have shown that when you give a baby riboflavin while they're undergoing phototherapy to reduce their bilirubin levels, that the bilirubin levels come down much more rapidly. But riboflavin absorbs some of the radiation, some of the light at the same wavelengths or similar wavelengths as you would get with the phototherapy. And some of those waves also come out in the sun. They've shown that when you give animals a large dose of riboflavin and then give them phototherapy that's similar to that which babies get, they get massive edema and damage to their skin. So we have to be concerned. We shouldn't give riboflavin in high dose to babies that are undergoing phototherapy, even though it brings the bilirubin down faster. I don't have a whole lot of desire to use megadoses of riboflavin. I like to use the lower doses, and they seem to be effective.
This presentation will continue on disc number 3. This completes the recording of disc 2.